Public Sector Consultants is Michigan's, reading directly here, Michigan's most respected, connected, and dedicated research and program management firm specializing in governance and regulation, healthcare, education, energy, and environmental policy. What I read there is that's not just a think tank, that's a think and do tank. And again, when we had Peter Pratt come to speak to us before, he was Senior Vice President. Today he's President of that organization, and he's agreed to come back. Could I have the second slide, please? Peter, I think our crowd will be very interested in this picture that was also on your website. Now, the description that I just gave seems to fit that first picture very, very perfectly. A very formal, buttoned-down corporate portrait. And this one with the guitar must have a story behind it. Peter, would you like to come forward and maybe tell us a little bit about that and begin your presentation? Please help me welcome Peter Pratt. Okay, here.
Oh, there we go. Everybody, I'm really loud, so I don't even know if I need a microphone. Okay, the story about this, anybody who plays the guitar knows that that is not the pose of somebody who knows how to play a guitar. That is somebody holding a guitar and doesn't is not even trying to play a chord. My avocation is the history of rock and roll, and I'm also available for future breakfast for business discussions. So I have clients who call me and try to stump me. Who wrote "Reason to Believe" by the song that Rod Stewart made popular in the early '70s? Anybody know the answer to that question? Tim Buckley. Okay, who sang "Indiana Wants Me"? Lord, I Can't Go Back There. Ardeen Taylor. Okay, so I have this one client calls me like every 6 months, and he said, "Okay, who's saying you're pushing too hard?" So that's why this is here. So that's not why you're here, though. So I'll get on to to talking about healthcare reform. First of all, thank you for. This is going to be a problem, I can tell. Thank you for having me again, Georgia, Chad, and the folks from Allegiance to talk about healthcare reform. Dr. Halsey has already said to me he can't wait to hear me talk about this crazy world we're about to enter. Let me just give you, first of all, my slides are really busy, and I'm going through a 12-step program to make them more user-friendly. So the next time I come here, I'll actually have a picture or two. I mean, Chad had to put them in so that we get that covered. So I'm going to give you a whirlwind tour here in about 20 minutes of the Affordable Care Act and what's about to happen. First of all, let me remind everybody what the Affordable Care Act was supposed to do. Okay? First of all, it was supposed to make sure that almost everybody had health insurance. Well, almost everybody is going to have health insurance starting in a little over a year, January 1st, 2014. Our people who have public or private coverage are going to be able to keep it. By and large, that's true. They're going to be able to keep it. Although one of the big questions is the extent to which businesses, especially small businesses, are going to decide that they are no longer going to cover their employees. The ones who cover them now are going to decide that they're no longer going to cover them and have them go to the exchange to get that health insurance. Private insurance needs more regulation. Unequivocally done. This was one of the big deals that helped move this forward. Medical device manufacturers, health plans, all made a deal with the Obama administration that in exchange for this extraordinarily large incoming population of covered people, either on Medicaid or private health insurance, they would take some hits. Okay, hits in terms of the way they're regulated, and hits in terms of taxes or fees that they're going to have to pay. Healthcare quality has got to improve. We got to start paying for quality instead of quantity. See, one of the reasons that I have a lot of words on my slides is I am in the fee-for-service world. okay? I get paid per word rather than the quality of my words. So that's why I put a lot of words in. I actually have a friend who writes for Booz Allen, and he gets paid by the word. And I said to him, what if you write crap? He said, I get paid by the word. We got to change this, right? Allegiance is one of the health systems in this state is leading this movement. The Affordable Care Act starts to get at this with some pilots and demonstration projects, but maybe doesn't go as far as some would like. And then everybody's favorite subject, healthcare costs, which I'm going to talk a little bit about more in a few minutes, are going up rapidly, and that's got to stop. Well, the Affordable Care Act really didn't do too much to deal with that. Almost every commentator who's talked about this has said that, is this driving everybody crazy? Figure out how to do this. I have to move or I become inarticulate. Okay. Okay. That was simple. Almost everybody who's done analysis of the Affordable Care Act says that this is more about expanding access than it is about controlling healthcare costs. And of course, as I'm going to talk about in a little bit, the wonderful thing about controlling healthcare costs is that every time you cut costs, somebody is going to be happy and somebody is not going to be happy. Whoa. Okay, I'm going to skip over this. I'm just going to hit the high points here. Okay, we're going to cover many of the uninsured now, okay, because of this. There is an individual tax. We can't call it a mandate, although I call it a mandate in the next slide, because of the Supreme Court decision that all individuals, with some exceptions, are going to be required to have either Medicaid, if they qualify, or private health insurance that they purchase, and if they don't purchase it, they're going to pay a penalty. Employers are going to have to pay a penalty too, but there are only certain categories of employers, and I'll get to that in a minute. There are tax credits and subsidies, significant ones, to help small employers and individuals purchase health insurance and limit the cost of health insurance. There is likely to be Medicaid expansion, although the Supreme Court ruling opens the door for states not to do a Medicaid expansion. I'm going to tell you in a minute why it's probably going to happen in almost every state. And there has to be determination of essential benefits. And the state has already produced a baseline plan. You can go on the State of Michigan website and find. One of the big issues that we're going to have to deal with from a healthcare delivery perspective is there are going to be a lot more covered people, either by Medicaid or by private health insurance. And right now, we have shortages of healthcare professionals in this state, in pockets of this state. And the question is going to become, who's going to take care of them? I gave a speech to a large physician group in Southeast Michigan 2 years ago. There were 120 office managers of practices there, and I asked them, how many of you are going to take new Medicaid patients in 2014? And one raised her hand. There is going to be increased Medicaid payment to primary care providers, but it's to Medicare rates, but it's only going to be for 2 years, and then unless something changes, it's going to go back to the rates now. The other big issue, the other big hope, I think, is that there's going to be a fostering of quality improvement because of the Affordable Care Act. The proven preventive services are now covered through Medicare, which work with no co-pays. There are going to be incentive payments, as I mentioned, for primary care and care coordination. There are also going to be penalties, and hospitals are starting to feel this now, for avoidable rehospitalizations. If somebody leaves your hospital and is readmitted for the same diagnosis within 30 days, the hospital takes a hit, okay, from Medicare. This is probably the most significant penalty that's ever been levied by the federal government for what they are determining to be poor quality care. We're going to start seeing the rise of organizations, accountable care, I keep calling them affordable care organizations, accountable care organizations, ACOs, that are going to bring hospitals, physicians, and lots of other folks in the community together to deliver care, okay, for which there'll be a standard payment, and if they do a good job of taking care of those people, then they will get a reward, okay, that will be shared with the federal government. Okay, right now, for the first time since I've been doing health policy in 26 years, the actual rate of people who are uninsured went down. Okay, part of the reason for this is the Affordable Care Act. I mean, the 26-year-old provision. I mean, apparently, it's so interesting when I ask people, lay people, to talk about the Affordable Care Act. The one thing they latch on to is, well, now my 26-year-old, I mean, there must be like 20 million 26-year-olds in Michigan. I mean, it's unbelievable. But this is the thing. Now I can keep my kid on my health insurance. So this and other things these and other things, that's actually a very small part of the reason, have been responsible for a lowering of the rate of people who don't have health insurance. We obviously, it spiked because of the economy, and a lot of people who had health insurance have lost it in the last 3 or 4 years. But now we're starting to see a downward trend. The Affordable Care Act is not going to mean that everybody is covered, okay? And because some people won't have to get coverage, and other people are going to choose to pay the penalty rather than get covered. But we're going to see in Michigan, if you combine the people who are eligible for Medicaid and actually enroll in Medicaid with people who are going to have to buy health insurance now because they are required to, probably 1 million more people are going to have some form of public or private health insurance. If you choose not to have this coverage, okay, you're gonna pay a penalty starting in 2014, and you can see how the penalties go up to a maximum of about $2,000, a little more than $2,000 in the coming years. This, of course, comes nowhere near the cost of health insurance. Okay, so a lot of people, and nobody knows how this is all going to play out, but it's safe to say that a significant, I would say, minority of people are going to decide that they're going to pay these penalties, okay, rather than going out and getting health insurance. There are some exemptions if you have low income and you have financial hardship. There are some religious exemptions for American Indians. 2 important points to remember, though. If you are an employer, you work for an employer, and your employer does not offer health insurance, you still are responsible for getting health insurance as an individual. Okay? And if your employer only covers the employee and doesn't cover the spouse, then they are responsible for getting health insurance. Okay? If your employer offers health insurance and you don't avail yourself of it, you still have to get health insurance somewhere or pay the penalty. I'm not going to go into the arcana here around the subsidies, but there are significant subsidies. And the subsidies go up to roughly $88,000. So you're talking about 75 to 80% of the people in the United States are going to be eligible for these subsidies if they choose to get health insurance on their own. Okay. Employers. Okay. First important point: if you have fewer than 50 employees, you are not subject to the employer mandate. Okay. The penalty, if you have more than 50 employees, the penalty is $2,000 per employee or $3,000 per employee who's getting the premium tax credit, which means that you're not, as an employer, you're not offering what's considered affordable coverage, and so they're eligible for that premium tax credit. The first 30 employees are exempt from the calculation of the penalty. So if you have 50 employees and you decide you're not going to pay, you're not going to cover them with health insurance, first thing you're probably going to do is let go of somebody, and then you'll have 49 employees. Then you won't be paying a penalty at all. But the first 30 are exempt, and you only pay the penalty on the difference between the number of employees you actually have and 30. If you have more than 200 employees, and Allegiance probably just sneaks in under this, over this line, right? Yeah. You have to enroll your employees automatically into the lowest cost plan, and so they have to opt out rather than opting in, which is the usual way we do things around health insurance. 98% of businesses are unaffected by this, either because they're too small or because they already offer health insurance now. And this all takes effect January 1st, 2004. There are subsidies, but the subsidies for small businesses are focused on the smallest of businesses. They are substantial subsidies, but I think contrary to the intention of the bill, of the law now, the subsidies, my experience is if you're a small business and you don't offer health insurance right now, the subsidy is not gonna, the tax credit is not gonna be the difference. You're not gonna go out and get it now because you have the tax credit. And if you have between 26 and 50 employees, which is, it just so happens that my firm has between 26 and 50, you get no mandate. We're not required to offer it, we do. But you get no tax credits either. Okay, long slide. Here's some of the big issues I think that the Affordable Care Act brings up. Okay, there are two kinds of costs we're talking about here. Every subsidy that I've talked about, okay, every benefit that the government is conferring, okay, on individuals or employers is adding to the cost of the bill, of the law. Okay, if you were giving tax breaks, and we're having a big discussion about the fiscal cliff, and this is one of the big issues here. All these tax breaks add to the cost of the bill. So the battle now is between how much the government pays and how much select individuals and businesses pay. And the last time I checked, we were paying for the government. Okay? I mean, that doesn't come out of thin air. Well, some of it does, but that's another question for another day. You can bring somebody in to talk about the deficit and borrowing. I'm not an economist. So every time it gets easier for individuals and businesses to afford health insurance, it's adding to the cost of the bill. So that's just something to keep in mind. The other issue is, how much money should people with health insurance pay to cover people who don't have health insurance? Does anybody want to, right now, roughly speaking, if you have private health insurance, you pay $1,000, and all of us, I'm guessing most of us in here have private health insurance. We are all collectively, all those people are paying $1,000 in our premium to cover people who don't have health insurance. So one of the ways you need to look at this, as skeptical as I know many of you are about the Affordable Care Act, is that the individual mandate is many times requiring people to pay now what they aren't paying when they get health care, when they go to the Allegiance ER and they're uninsured. You know, I'm sure that Georgia and Chad don't take them outside and say, you better find about $3,000 here real quick or we're not going to take care of you. That's not how it works. So one thing to keep in mind. The other thing to keep in mind is that the average health insurance premium now for a family coverage in the United States is $16,000 a year. Okay? The average employer pays 72% of that bill, and the average employee pays 28% of that bill. And those proportions are unchanged in the last 12 years. Now the amount is going up because healthcare coverage is going up, but that percentage, so the average person who's getting employer-sponsored health insurance, employee, is paying about $4,500 in premium, not to mention copays and deductibles. I'm going to move quickly here. Expansion of public programs, I've talked about this. The important thing to remember here is that the federal government, otherwise known as the American citizenry, okay? The federal government is going to pay the lion's share of the expansion of Medicaid. Okay? That amount, though, is going to decline. You can see in my sub-bullets, down to 90%. Now, you think, well, that's great, they're paying 90%. Well, 10% of billions of dollars is a lot of money. And so there's a lot of concern that states aren't going to be able to afford that. The good side of this is, though, that there are all sorts of things now that are going to be covered that were not covered before, especially mental health. So as this group expands, as I mentioned, you're looking at 500, 600,000 more Michigan residents are going to be covered by Medicaid. We're going to save $1.3 billion. The federal government is going to pay $1.3 billion over the next 10 years. So even with the 90% in 2020, there's going to be a net savings to the state for expansion of Medicaid. That's why, and it's true in almost every state, that's why I think in the end, you're going to see Medicaid expansion go through. The exchanges, I know people are really interested in the exchanges. What's happening in Michigan is that there is going to be an exchange, but it's going to be, my fourth bullet is incorrect now, because last week the House Health Policy Committee refused to report out a bill that would have allowed for the possibility that the state could establish its own exchange. That's not going to happen now. And pretty much Governor Steiner, who's been fighting very hard for this state-based exchange because it gives us more control as a state, has thrown in the towel. So we're going to have a state-federal partnership on this exchange, and at this juncture it's unclear to me what that means. The feds have not come out with regulations that are going to govern the relationship between the state and the federal government, but the federal government is going to have a very strong role in the Michigan exchange, which is where people, individuals, and small businesses can go to buy health insurance. The hope is that these, anybody here, and I mean no disrespect to insurance companies or insurance agents, but trying to compare, I mean, I do health policy for a living, and when we decided to switch health insurance plans, it was, I got a migraine. It's just really hard to compare apples to apples when you're trying to decide whether you're going to change from one plan to another. Hopefully, the exchange will try to make it easier to compare plans either within one company or across companies. This is going to happen in a year. In fact, the exchange has to be ready to go in October of next year so it can start enrolling people. So health plans have to be qualified. It's going to be a whirlwind, stay tuned, but we will have an exchange in Michigan that'll be a federal-state partnership. I've talked about the regulation here, I'm not going to go through this. Just, you know, suffice it to say that these are the provisions of the law that I think even if Romney were elected president and he repealed large chunks of the Affordable Care Act, he would not have repealed these chunks. Okay, because these are very popular with the American public. No, you know, reduction on limits on pre-existing conditions and things like that. Cost containment, because I'm almost out of time here, I'm going to move through this quickly. Important things to remember. Everybody is going to reduce fraud, waste, and abuse. Everybody is constantly reducing fraud, waste, and abuse. Okay? The best description of fraud, waste, and abuse I've ever heard is by Uwe Reinhardt, who's a prominent health policy. He's an economist at Princeton. He said the problem with healthcare fat is it's marbled into the system just like fat is marbled into beef. It's not all out on the edge and you can cut it off. Okay? I'm not defending it, I'm just saying it's very hard to identify, and oftentimes you spend more money trying to find it than you do preventing it. There are going to be significant reductions in payments to inpatient hospitals, nursing homes, home health, and others. Excuse me. There are going to be reductions in payments to Medicare Advantage, which are the Medicare HMOs. So there are some significant cuts here. I mean, in the scheme of things over years, these are not large numbers when you're talking about, you know, $2.5 trillion healthcare budget. How are we going to pay for reform? This is one of my favorite slides because everybody says to me, well, how come this costs almost $1 trillion and yet we're saving money? Well, in healthcare, and everybody who's in healthcare in the room knows this, in healthcare we don't talk about costs going down. Costs don't go down. What happens is now we have a new phrase for it, and it's nice every 10 years there's a new phrase. The new phrase is bending the cost curve. So we are making sure it doesn't go up quite as bad as it used to. That's how you can have $1 trillion plan over 10 years and still not add to the deficit. In other words, this is going to cost a little less than healthcare would have cost if we didn't have it, according to the Congressional Budget Office, which is nonpartisan. There are going to be higher Medicare taxes if you're higher income. There's going to be an assessment on unearned income if you're higher income, 3.8%. Okay, there are going to be taxes on Cadillac plans. If your plan has an actuarial value over a certain amount of money, you're going to be taxed. There are the penalties that I've talked about, the cuts to provider payments, and the medical device manufacturer. So there are lots of cuts built in here. But again, I mean, here's the thing. That one of the interesting things about the presidential election was that people were battling over how we're going to cut Medicare. Okay? Seniors don't like to cut Medicare. Okay? There's a discussion about raising the eligibility rate to 67 years old. How many 66-year-olds are opposed to that? Okay? I tell you what, I'm 55 right now. In 10 years, I'm opposed to it. Okay? But we've got to do stuff like this. I mean, the question is whether we do something surgically that sort of makes sense, or whether we just do across-the-board cuts that wax good things and bad things alike. And my last slide is the fiscal cliff. All the budget numbers I've been throwing around here are subject to this debate about the fiscal cliff that we're going to go over, as everybody knows, on December 31st. If there's not an agreement, the Bush-era tax cuts are going to expire. Every economist, the left, the right, agrees that the fiscal cliff is not a good thing. What they don't agree about, and obviously the Republicans and the Democrats don't agree about, is what we do about it. So, if the fiscal cliff occurs, these are the things we can see. They're going to go into effect immediately. 2% cut on Medicare, 27% cut to physician payments. This is the sustainable growth rate debate that's been this can has been kicked down the road for years and years and years. Hospital payments are going to be cut, possibly. Medicare and Medicaid are on the block. Okay, everything I've talked about is going to be subject to cutting. So I guarantee you, if we go over the fiscal cliff, healthcare costs are going to go up for you. I guarantee it. Okay? Things are going to get cut. Medicaid expansion may be limited, which means we'll have more uninsured. The subsidies that people were eligible for, going up to 400% of federal poverty level, are going to go. They're not going to go away, but they'll be diminished. So this fiscal cliff discussion is a huge discussion about the Affordable Care Act as well, because there's going to be an agreement, whatever they agree to. I mean, we may go off the fiscal cliff, but my guess is if we go off the fiscal cliff, we'll go off for like a week, and then we'll, climb back up. It'll be scary, but it'll be a climb back up. And the upshot of this will be that there will be an agreement, but this agreement will change. I don't think it will monumentally change the Affordable Care Act, but it will add to the cost that individuals pay. The debate now is whether that additional payment to avoid going over the fiscal cliff is going to be borne predominantly by upper income American residents or everybody. That is all that I have. Thank you. I'm going to turn it over to Georgia.
Thank you, Peter. We are going to save time for our questions at the end. And Chad, maybe we can post these slides on the website. Chad, the Breakfast for Business website, because it's really, I apologize that it's hard to see the slides in here. And we'll do the same with the ones that I'm going to show. I think that I know most all of you in the room. For those of you I haven't met, it's been my privilege for the last 23 years to be associated with Allegiance Health and to witness that a team of people really willing to come together and transform a small community hospital that, by our own admission, had a reputation for inconsistency and mediocrity, into a health system that our community can be proud of and is recognized at the state and national level for our work in quality and safety, as well as investment in the community. When I arrived in Jackson, one of the first meetings I came to within my second week of being here was Breakfast for Business, and it was a small group in our auditorium, and I thought, this is really unique, and maybe it's what small communities do. What I didn't fully appreciate at week 2 is the level of collaboration in this community that allows us to do very innovative and creative things. And that's what we want to talk about, health and healthcare. And that's the purpose of the two physician speakers that you're going to hear. So what I want to focus on is Peter's slides on ACA and the fact that we've only made a dent in healthcare quality improvement, and that the way we pay providers is going to be a key to that, because Peter's right, we're paid by the word. And right now, the sicker people are, and the more we do for them, the more the healthcare delivery system makes. But that becomes an employer's expense and an individual's expense. And also the fact that healthcare costs are rising too rapidly. Our ability to upright the economy of the United States is going to be focused largely on our ability to manage the per capita cost of healthcare. And this isn't just Medicare, the part, and Medicaid, the part the government pays. It's also the cost to individuals, because it's affecting our own economic survival. And then as employers, for many of you who continue paying those costs, you know that that is a huge and growing line item in your budget that we haven't been able to manage. I have a little bit different perspective from Peter on the 26-year-olds, because we've heard this is the 19 to 26-year-olds from our own staff, how elated they were that they were able to add their children. What I heard was how scared they were when they knew their children went without coverage. And I think that tells us how important that we understand the value of insurance. The other thing we've heard so much about is people who, the 14% of the individuals who were unemployed, who went for, and still are going through periods of time in their own personal lives without health insurance, and realizing the value of that insurance card whenever they had a health issue. So at Allegiance, going back to this Breakfast for Business and the things that we have done together as a health system working with employers, this has been a 12-year journey starting back in 1999, where we really got serious about investing in community health improvement. And one of the first coalitions 10 years ago was the Jackson Business Leaders for Health, which I'm going to talk about in just a second. We'll do next slide, Dave. One of my early introductions after I became CEO, and we owned then Physicians Health Plan, an HMO that was regionally based, and we owned the Jackson Plan. In 1999, the actuaries came and said that our rate increases were going to be 40%. Otherwise, the plan was going to have to subsidize the community. And that was when, at a board meeting and then subsequent call with the brokers, I was told I needed a reality check if we thought that the community was going to pay 40% rate increases. But this was a reflection of the health status of the community, of the disintegrated care, of the piecework, pay by the word. And what we were hearing from employers is that they were going to decrease benefits or else cancel their policies, that it was going to affect their ability to stay in business, or they were going to cost shift to the employees and they wouldn't pick it up. So we needed to do something different, and that's what led to our journey here. The Jackson Business Leaders for Health came together to have a forum to really talk about the fact that there needed to be a serious investment in health. And that has led to a number of innovations over the last 10 years in the health improvement organization that we have that's made us very different. So what we're going to be sharing with you today through two of our physician leaders is the innovation that we have been able to start in Jackson. This is a long journey going from this what we call first curve of healthcare, uncoordinated care, where the costs just grow exponentially and the outcomes aren't what they could be if we had a coordinated system of care. We're here in the middle of trying to bring the parts and pieces together, and you'll hear about that from Dr. Halsey. And we have the early stages of a community care model here as well in the roots of our clinically integrated network and other work that we're doing. So what I would like to do, our medical director of the clinically integrated network couldn't be here today. And I'm going to introduce you to a video done by Dr. Michael Klinkman. Dr. Klinkman is a board-certified family physician from the University of Michigan. He works with us 20% of the time. His interest is in population health and communities that are able to create innovations and partnerships with the community, with the employers, with hospitals, physicians, and other caregivers in order to be able to invest in the health of the population in a way that will reduce the per capita cost of healthcare. This is about a 9-minute long video, so we'll start with that.
So I'd like to start just by thanking you all for letting me come and talk to you in this way. I always feel awkward about just being a talking head that can't communicate directly with people. We'll have to make this do for now. I hope that we'll have a chance to talk about these issues in a give and take fashion at some point in the near future. Just to let you know who I am, I'm Mike Klinkman. Above everything, I am a practicing family physician. So everything that I say from this point on, put it through the filter of me being a family doc. I'm a professor of family medicine at the University of Michigan, and I've been working there for the past 20-some years. I've been taking care of my patients in my practice for that length of time, some longer from when I was in training. So I come at this with the idea always about taking care of a group of people over a long period of time. And in my role at the university, I've done a lot of things, including trying to build population health programs, trying to learn how to do disease management for populations, and I've learned firsthand about the way that these sorts of things can succeed or fail. Probably the reason why I'm here talking to you is that we've been back and forth trying to build ways to put and integrate mental health in primary care for a long time. The work I've done in my own environment in Ann Arbor, work I've done across Michigan, some of the work I've done internationally is all based on trying to do what I would call person-centered medical care. That means everything from trying to be the place where all of my patients come as a first line of service, to understanding how to help coordinate care when it's not just me taking care of people. And in that, I've learned a lot of stuff. I mean, you've already heard earlier in this morning about how healthcare is broken, how our system is broken, and you probably can take one step further back and decide that it's not really a system at all. It's just a bunch of moving parts, and the parts are hospitals and emergency rooms and primary care docs and communities, and all of this is based on trying to provide technical services to the few people that get in for care. And that's not a system at all. I've had experience around the world looking at and learning about and working with systems of care. And I'm not sure that you can really call what we have a system. So what we're talking about today is an approach to try to make a system of care, to try to make something that works across a community and trying to do that the right way. Too often, healthcare reform has just tried to move one little piece of the puzzle a little further ahead without bringing everything else along with it. So when you look at it from the perspective of the person receiving care, it gets more and more complicated, more and more people involved, more and more moving parts, and it's really hard to make that all fit together as it gets more and more complicated. So, why am I here? I'm here because I see an opportunity to do something beyond what we have been able to accomplish in a lot of settings around the country. Some of you have heard for the past few years about this thing called the patient-centered medical home. That's the way we're approaching fixing medical care and transforming care to work for people. The problem is the patient-centered medical home goes one step. So you've got patient-centered medical home, a place where people can come to get their health care, a place where they can go where they can at least have a first pass or a first location. But it still is focused on an individual practice. It's still focused on medical care. And you might bring additional people in to help serve, but that can also make the process of care more complicated. And in fact, so far, what patient-centered medical homes have done is they've done some population management for chronic disease, and they have been able to report out outcomes for chronic disease, but they haven't really moved care to make it more integrated or more accessible for the average person. So you move from the patient-centered medical home in thinking that it's going to be this isolated thing, and trying to think about how to make it a patient-centered medical neighborhood. That's one of the new catchphrases. The problem is that that still is medically centered. It's still centered around primary care practice and maybe specialty care or a hospital, but it still is medically centered and not community-based. So it's still not quite enough to get beyond the isolated kind of fragmented care model. So what we're trying to think about here is something called a patient-centered health community. So we're changing just a few of these words, but those words are really important. So instead of it being medically focused, we're trying to think about health. We're trying to think about preventive care. We're trying to think about engaging people in care who don't get into care now. We're trying to think about it moving beyond the traditional medical boundaries of primary and specialty care and hospital care to reaching into the community. And that's a model that has some traction. It's a model that can work. It's a model that can be based around a community that supports itself in a lot of ways. It involves employers and people living in the community and community outreaches and social services as well as the medical system. And that's a place where you can really talk about health then instead of medicine. So one of the things to take away from all the talk that we do here today is that we're trying to think about this as a patient or person-centered health community, and that's our goal. Now, I came here a couple of years ago because I was looking for ways to try to test out innovations in healthcare, to try to bring mental health care back into the medical care setting and primary care. And as I started to do that, I realized that this was a place that had a lot of pieces in place to actually make this idea of person-centered health community-based care a reality. You don't have warring factions of one hospital versus another. You don't have one group of specialists versus another group of specialists. You don't have 25 different electronic medical records that you try to have to bring together. And so some of the pieces that were necessary to make this sort of an approach work are already there. And you have already had leaders in the community thinking about this and planning for this long before I ever walked on the scene. So with that in mind, you've got some of the pieces. You've got a Jackson Community Medical Record where physicians in primary and specialty care share the same platform so that they can move health information better. You've got a behavioral health summit that is thinking about ways to bring behavioral health care and mental health care back into the mainstream of care in the community. You have an award-winning health improvement organization that has for years been thinking about ways to reach out and engage people in getting care that's needed in the community. And you've got foresighted employers and health systems that have thought about ways to bring this together, again, before I ever landed here. And those sorts of resources or those sorts of building blocks being in place is pretty rare. In many communities, you have none of that. Even where there's interest in trying to make community-based care, you have to overcome a lot of roadblocks and hurdles and jealousies and turf wars, and we've gotten away from some of that here. So what I see as the opportunity in this time, in this place, is that we can bring together clinicians, and the work that Dr. Halsey's told you about the Jackson Health Network and how the board came together and how clinicians came together is a great story about how that happens. You've got a hospital and a health system that's thought about the future and about how to reach out and engage providers in the community in caring. You've got a community outreach group that has thought about how they could bring people into care. And then you have this transformation that we want to take place in the medical home so that people who have health needs know where to go, can have help in engaging the care that they need, both preventive and curative, in a system that supports them as they do this. That means a lot of stuff, but my job here now, and the reason why I came is because these pieces are in place. It's a great opportunity to bring together not only the people, but the health information resources that you have to make this happen. So you've got an electronic health record that will work across a community. You also need pieces of connective tissue or things that you can do to connect the dots so that those people that provide care who aren't physicians can also share information. And that's the other part of my job and something that we're hoping to build here over the next 12 to 18 months. So to make a long story short, the reason why I'm here is that this is a great place to do something that I think is truly innovative. I think that we can move past the patient-centered medical home in its isolated kind of maybe better but still troubled way to build a person-centered health community that works for everybody, not just people who have health insurance, not just people who are employed, but everybody who lives here. And if we can cross those boundaries that are insurance-based or market space-based or employer-based and bring everybody around the table and make this start to work, I think in the end we'll have a community that really functions and that provides the health that the people inside the community need. So that's why I'm here. I'm hoping that I'll be able to come back and talk to you all about our success in the future. For now, I wish I could just stay here and answer questions and show you all the great diagrams we've built to support this and the care model we built to support this. But it's coming, and just be patient with us over the next year or so. And I guess for that, I'll say thanks, and we'll talk to you later.
Just turn this over to you. I'm sure everyone in the room knows who you are, but maybe
Well,
a brief introduction would help.
Probably not everybody, but I probably know most of you, and I appreciate you guys all coming. I'm David Halsey. I was born and raised here, and I'm kind of filling in a little bit for Ray King, who's the CEO of our Jackson Health Network. I'm the chairman of the board. He's out giving a talk out in Colorado. They're very interested in some of these innovative things we're doing, and actually he's out there with a company called Phytel, because again, we are quite an innovative community, so I'm filling in a bit for him. I've been born and raised in Jackson. I've been here 27 years. I work as an endocrinologist and a general internist. And again, I know most of you here probably, so thanks for coming. We appreciate Peter's review of this new Accountable Care Act. It's kind of scary, but I thought it was a great review, and George's history of kind of how we got to where we're at. The new health care bill and health care reform are really being driven, in my mind, dramatically by two things. The first thing is this a dramatic and non-sustainable increase in cost, and everybody knows that. If we didn't have this cost concern, we probably wouldn't even be here. But the other issue is outcomes. People tell me that we have the best healthcare system in the world, and we do for individual people. You can get the best healthcare in the world here. But if you look at our population outcomes, they're not so hot. You can have the first slide. I'm sorry. Our population outcomes are not so hot when you compare us to around the world. And there's this disconnect between the available best healthcare in the world and yet our population outcomes. And because our population outcomes are not good, it costs us a fortune, and those costs are unsustainable now. So the question is, how can we fix that? Now, several people have alluded that a problem is the way we've been paid. If you think about this, when I have a sick person and I send them to the hospital makes money. If we don't have sick people to go to the hospital, they don't make money. Most physicians, we have been paid to take care of sick people, which we need to do. I mean, if you're sick, you want your doctor to take care of you. But the problem is if we use that payment method, no one has any incentives to try to cut costs. So our payments need to change so that we're incented to pay for health, to try to keep people out of the hospital and try to keep people healthy before they get disease. And that's going to be a tricky thing. How do you maintain a health system that is geared toward treating the sick and still not go financially broke when you are trying to keep people healthy and out of the hospital? So we need to incent the desired outcome of keeping people healthy, and the new payment systems are going to do that. To do that, though, to keep people healthy, we really need to have these integrated systems. We've talked about this fragmented care, and you can't keep people healthy just treating them in these silos of the physician's office and the hospital, etc. You need the whole community to make people healthy. And when we make people healthy, we will decrease the cost of care and increase our population outcomes. Now, part of the problem has been this last bullet here. Up until recently, the federal government has not really allowed us to work together as a medical community, physicians and hospitals, because of antitrust issues. There was all kinds of antitrust issues, but they've realized that if we're going to have an integrated system of care that's going to actually affect population health outcomes, we need to be able to work together as a team and as a system. So they have relaxed some of those fairly recently, and they're allowing physicians and hospital systems to come together and form new companies and actually work together and bargain and deal with the payers and help rates and things like that without so much antitrust concern if you stick to their strict guidelines. So this is allowed groups like ours, our clinically integrated network, the Jackson Health Network, to come together without so many fears of antitrust issues, as long as we follow strict guidelines. So this is going to be something that's going to allow us to create this community system of care without going against the federal law. So what is a clinically integrated network? Well, again, it's a legal entity. We thought of many ways to try to set this up. We've been working on this for 2 to 3 years, and unfortunately I can't go through all the details. We don't have time. We want to save time for questions. But we've been working on this a long, long time. And basically, it is a legal entity that is allowed by the federal government to join, again, physicians in the healthcare systems to work together as a company and avoid these antitrust issues. And we are going to it aligns payment method with a new delivery system. So we are going to reward wellness and keeping people well. And that way, everyone will have a financial incentive to try to keep our healthcare costs down. So, again, we've been working on this a long while. We debated forever whether we should have a true partnership, a joint venture partnership between the physicians and the hospital system, or whether we should be an affiliate, a subsidy of Allegiance. And because of many financial reasons, our startup costs, and also the tax benefits for being part of the Allegiance system, we have become a subsidiary of Allegiance. But we have our own board, which has really very, very strong powers and really acted quite independently from the health system. Everyone knows that if we're going to have a system that is going to try to keep people healthy, we need to have the people who deliver the care, the medical leaders, try to have a major part in running this. So if you look at this, we have 14 physicians out of a total of 18 people on this board. It's very heavy in the physician numbers, and we all thought this was important. We've also made it very, very diverse. As you guys probably know, there's a big, there's some people think there's a division in the community, in the medical community, between what are becoming employed physicians, which is a national trend, and more independent physicians. We're very aware of that, so to make this work, 7 of our doctors are independent, and 7 of our doctors are employed by Allegiance. We have made, there's always a potential division between specialists and primary care. We're aware of that, so we made 7 of our physicians primary care and 7 of our physicians specialists. We've got a very diverse group. They're an excellent group of people. And we, again, have hired Ray King to be our CEO. He is hired by our board, and he does the day-to-day running of this business. Obviously, since we're part of Allegiance, we have and welcome, obviously we want the healthcare system representatives. We have 2 of those on our board. And also, very importantly, if this is going to be a patient-centered community health project, we need community representatives. So we have 2 community representatives on there that are supposed to bring to us the concerns of the business community and the community at large to try to help this system work. So we think we're very well equipped at the board level to make this work. Now, one of the things that the federal government said, okay, you guys can come together as a new corporation, a new company, and work together and avoid some of these antitrust concerns. But to do that, we have to prove to them that year after year after year, we meet these 3 requirements. And if we don't meet these 3 requirements, they will not let us continue to be a clinically integrated network. And these are improved health outcomes and improved patient experience. These are the triple aims that Georgia had in one of her slides, and impact the overall medical cost curve. We need to bend the cost curve. We'd all like to try to get the costs lower. I'm not sure that's going to happen, but we clearly need to stop this accelerated rise in healthcare. And we need to keep doing these things to still let the federal government let us become a clinically integrated network. So this is something that we're going to be very aware of. So how are we going to do that? Well, we have a lot of things in place. Dr. Klinkman talked about our community health record. our community health record is an absolute necessity. And we are way, way, way above the curve in this. As you know, the federal government's basically making people have electronic medical records over the next few years, or they're not going to be paying them as much money for their office visits. But they don't really specify what type of electronic health record you need. And the vast majority of people around the country will just have an electronic health record in their office that keeps their office stuff. But it doesn't communicate with other doctors, with specialists, with the hospital, with the emergency room. And ours is very, very, very different. This is a community electronic health record, so when I'm on it, the specialists who are seeing one of my patients can review all the data. We can get stuff from the hospital, and it's a much, much different system. It's also much more complicated, and the system is certainly not perfect, and some of you have probably heard that we're not all real happy with it, and we're not, but we all know that it's the right way to go, and it's getting better and better and better and better. This is a major advantage of the Jackson community that most communities don't have, and that's been supported. It's been very expensive. Jackson Physician Alliance and Allegiance have both supported this, and it's going to be one of the things that's going to put us way ahead of the curve as far as these clinically integrated networks. We're also using local expertise and leadership in this, and we use proven data, proven ways to improve healthcare outcomes. We are not going to we're going to reimburse people based on wellness and how well their patients are. Just as a quick example, with diabetes, we check a test called a hemoglobin A1C every 3 months. Well, a lot of the insurance companies are looking at physicians' offices and seeing, do you check the hemoglobin A1C every 3 months? And if you don't get as much reimbursement. But the clinically integrated network to improve health is taking this a whole step further, because we're going to reimburse people based on how good the hemoglobin A1C is. You can check it every 3 months and get payments from most insurance companies for that, but you could have terrible hemoglobin A1Cs. That's not improving health. So we're going to incent people with evidence-based medicine techniques to actually improve health. So when your hemoglobin A1C and your patient is good, you're going to get more incentive. You're going to get more financial incentive. And so that's just one example about how we're going to use this. We have 60 or 80 metrics that we're following. Most of them so far are for the primary care doctors, but we're developing all those for the specialists as well. And every one of our physicians is going to be incented to provide health instead of just taking care of the sick. And that's the way you cut down healthcare costs. And this integrated approach is the only way to do it. We must also do it, with not just the hospital, but also the whole community. And we're going to do this expansion to the patient-centered medical homes. But again, like Dr. Klinkman said, this needs to be a patient-centered medical community. We need the entire community to do this. And that's going to be very, very important. So what does this mean to the business community? Obviously, if we can make a healthier community, it's good for you because your employees are going to be there. They're going to be more efficient because they're going to be feeling better. They're going to have less health issues. They're going to be much more higher functioning. And also, though, when we do that, we're going to be hopefully containing these healthcare costs. If we make them healthier, it's not going to cost so much. And if it doesn't cost so much, that's good for the employers. And so this is going to be this is a big benefit to you. And of course, if you can get a healthier community, it's a more attractive community, more people coming in, more businesses coming in. To do this, we are going to at least yearly give you guys a report card, the business community, a report card about how we're doing about these health outcomes that we're actually measuring. We've got 2 community members, but we want your input about what's important to you as far as health of your employees. What can we do to incent the system, the clinically integrated network, to improve the health of your employees? So we want you to give us input about what incentives we could give to the system to try to help you. And I think that's going to make it more of a community, a patient-centered community health system. And I think that's going to be very good for Jackson. And I think that's all I have as well. So thank you very much for listening, and thanks for coming. Again, this has been 2 or 3 years in the process. I don't have time to go over all the details, but we'd be happy to come back and go over details or answer details of this Jackson Health Network anytime you want. So thank you very much.
What we want to do right now is be able to get your questions. This is an opportunity to be able to hear from you about how this will work, and many of you are faced with trying to respond to the Affordable Care Act, et cetera. So Chad, do you want to give us instructions on this?
Let's see, and we have a number of people who can answer these questions. Who will pay the primary care physicians and the rest of the care team these incentives to keep patients well? And how is the, Dr.
Okay, the way the system is
already
right,
on this.
the way the system is right now, there's going to be, like we have now, this is in state of evolution, but right now we have a fee for service. So if you see a patient, you're going to get a fee for service. That fee for service is going to be hopefully in the future negotiated by the Jackson Health Network with payers. So we're going to be negotiating on behalf of the Jackson Health Network the fees that get paid for fee for service from Blue Cross or wherever. The incentive payments will also be negotiated by the Jackson Health Network. So we're going to be talking to Blue Cross or whichever insurance to say, listen, we want the fee-for-service rates, but we also want an incentive to incent health, a financial incentive. Those fee-for-service or those incentive payments will come to the Jackson Health Network, and then the Jackson Health Network board decides how those are going to be split up between the members of the Jackson Health Network. So the Jackson Health Network board, not Allegiance, but the Jackson Health Network board decides how those incentives are split up, but they're going to be negotiated by the Jackson Health Network with the payers.
How will the government determine the 30-hour rule for part-timers to be eligible for health care coverage in 2014? Peter, I think that might fall on to you.
Yeah. There's a formula. Yeah, I'm from the government and we have a formula. I don't know it exactly, but it's an average. It's an average of your employees, so that the full-time, it's the number of hours that they've worked in the previous year, or something to that effect. If somebody knows the answer to this, I'm more than happy to defer, but I think that it's an average, so you're not going to just sort of take it on an individual case-by-case basis to determine whether or not somebody is a quote-unquote full-time employee. Does anybody have? Okay. It's scary when I'm the smartest person in the room on this particular issue. But it is an average. It will be an average, and you're right. The threshold is 30 hours for full-time employment.
Don't sit down yet, Peter. This one is even addressed to you. What is your estimate of how many employers will bail out of providing health insurance, and how fast will that happen?
Okay. I do a lot of work with the Small Business Association of Michigan, SBAM. And I've had a lot of conversations with Rob Fowler, who's the executive director of that organization. And he's no big fan of the Affordable Care Act. His opinion is that fewer than you might think are going to drop out. The reason, he says, is that people who offer health insurance right now, even small businesses who could do it with impunity, right? I mean, if you're under 50 employees, you won't be punished as an employer. Do it to attract talent. And so those people who are offering health insurance now are probably less likely to give it up. You're not probably going to see a lot of people who aren't offering it offer it now, but his feeling is it's not going to be a lot. Now, having said that, there will be some who will. The other point that often comes up here in this discussion is that there are a lot of employers, a lot of small employers who offer health insurance because, not necessarily to attract talent, but because they feel they have to, because they feel they owe it to their employees. I mean, they don't want to see them uninsured. For those employers whose primary reason for offering health insurance is because they would have nowhere else to go if it weren't offered through the employer, you're going to see some drop-off because now they will have somewhere else to go. They will have the exchange. They will have significant subsidies on the exchange. okay? The other complicating factor here is that a lot of employers, again, who are concerned about the welfare of their employees, are afraid of what's going to happen if an individual employees are sort of thrown out into the open marketplace. Nobody knows how these exchanges are going to work. We have two models that are already going, one in Utah and one in Massachusetts, very, very different states, very, very different exchanges. And so you may see some employers hold on to insurance, if they can afford to hold on to insurance, if they are concerned that they're sort of throwing the employees out into this totally, mystifying new world of individual health insurance. The bottom line is the economy. If the economy approves and there's competition for workers, you're going to see fewer small businesses drop employer-sponsored health insurance. I don't think you're going to see significant large employers dropping coverage.
Peter, I think I'll have you stand here. I think no, seriously, I think I've determined which questions might be easier for you and more local. This one is a two-part. Why not promote competition to improve healthcare results and reduce costs? And why not just go back to a cash system and get rid of the insurance component?
Okay, I'll answer the competition question first. It's easier for both Georgia and the two physicians who spoke talked about the uniqueness of this community. I do a lot of work in Michigan. This is unique. This is really cool stuff that you are doing in this community. So, what does that have to do with competition? Well, I think that you're going to start, one of the interesting, everybody talks about, well, where do you go if you get sick? If you get sick, where do you go? You go to Mayo, you go to Cleveland, right? Everybody talks about, if you get cancer, you go to MD Anderson in Houston, okay? I think things are going to start to change in this world. And I think Jackson has a real opportunity to be a leader. There is a health system in rural Pennsylvania that everybody in health policy circles knows about. It's the Geisinger system. It's hospitals, many of which are smaller than Allegiance. And they have put a plan together that is in many ways akin to what is being hatched here in Jackson. If you can truly start to pay for outcomes and reward physicians and hospitals for keeping people out of the hospital. I'll probably never get asked back again by Allegiance when I say this, but the way you control healthcare costs is you pay hospitals to keep people out of hospitals. That's a vast oversimplification. I said this is, I may not even get to finish this question, but no, I think Allegiance gets that. You're always going to have sick people, as others have said, you're always going to have sick people. You need to take care of sick people. The baby boomers are going to get old and they're going to get sick. So you're going to need to take care of us. Okay, I understand that. But really, we need to come up with a system that is going to keep people out of the hospital. And that will confer a competitive advantage on hospitals and physicians who can do that. And the way you keep people out of the hospital is you recognize, okay, that hospitals and physicians alone are not the only way to keep people healthy. There's one of the famous quotations that we bandy about in health policy circles, which now I'm going to alienate every physician in the audience, is you'd be better off giving up smoking and physicians than keeping both, okay? You're going to eventually need docs. I don't mean to, and I've had some weird, stuff go on then, and I don't smoke. But what I've heard this morning tells me that the physicians in this community and the health system in this community gets that, okay? And that is going to confer, if we can get the payers, if we can get Medicare, if we can get Blue Cross, if we can get the other payers to pay this way, really pay this way, and not just sort of stick their toe in the water, then you guys are going to have an enormous head start. And that's the kind of competitive advantage I would like to see, where you get rewarded for keeping people healthy, or managing, if they have chronic illness, manage it. Okay, what was the other one about, why don't we go back to insurance? Why don't we get rid of insurance?
Cash.
Okay, this was asked by a person who's never been sick. I have two perspectives on this, okay? I'm not going to get too personal, but I take relatively good care of myself. I exercise 5 days a week, okay? I don't smoke, I don't drink. I know I need to start drinking red wine, I understand that. I'm not, you know, my BMI is not that of a marathon runner, but it's relatively healthy. In the last 5 years, I have been in the hospital for 4 days, 3 different times. And that would have bankrupted my family. And I'm lucky. I have a good job, okay? That's why I don't like a cash system, okay? The way to do it, and you're starting to see this, and we actually have a health savings account in our company, is that you need to protect against catastrophic illness. You need to protect against getting people, you know, who get sick through, you know, because of things outside of their control. And you need to give some incentive for people to manage costs. What's interesting about that is that the University of Michigan has pioneered this thing called value-based health insurance design. And they focused on people who are chronically ill, who are taking meds. And what they figured out was something, I know if you sit down and think about it, it makes perfect sense. Is that we need to do everything we can to get people who are on medications to take them, because if they don't take them, they're going to end up in the hospital. Once you get to the hospital, I go back to what I said earlier. No disrespect to Allegiant. So they actually have large companies like Pitney Bowes and others who are paying no deductibles on high-cost drugs, because they can then, and they also have workers who are helping them make sure that people, and these tend to be elderly people who have chronic illness, to take these drugs, and they're saving money by by getting rid of deductibles. The challenge in healthcare is you want people to take personal responsibility for their own health, but you need, it's so hard because what the incentives that individuals respond to are so individualized that what's going to work for Chad is not going to work for me. And so we need to find a way, and there's more precision around this than there used to be. We need to incent people to do things that are going to keep them healthy, but we don't want to keep things away from them that are going to help them stay healthy. So I mean, insurance is, in my world, is a necessary evil. Just to put it into perspective, 50% of the nation's healthcare costs, this $2.5 trillion, are incurred by the 5% of people who are sickest. The 5% of people who are healthiest, okay, I'm sorry, the 95% of people who are healthiest use only 5% of the healthcare cost. 90% of the healthiest use only 5%. So you have this enormous imbalance, and some of that has to do with decisions that have been made over the course of a lifetime. I understand that. But a lot of it doesn't. So the challenge is, how do we incent people through the insurance system without throwing, millions of people into bankruptcy because they can't afford to pay their health care bills?
A couple of local questions. This would either probably go to George or Dr. Halsey. What is the role that the county health department plays in integrating care?
One of the things that I also value about the community is the degree to which the county health department has been willing to partner with us. And they joined the Health Improvement Organization early on, some 10 years ago. And also, we merged the health system's community health goals. The county was also adopting its own goals for health and other aspects of their strategic plan. And so they asked if they could work with us on advancing those specific health improvement goals. That's very unique. And the other thing that just happened recently, the medical director of our health improvement organization, Dr. Amy Schultz, has become part-time medical director. I think this was a couple of years ago at the health department for Jackson, and most recently with the upcoming retirement of the health director who serves Jackson and Lenawee County. Allegiance and the county agreed that we would come together to hire one person. And so I'm very excited about the opportunities to look at how the public health department and the hospital can work together. And the one thing I want to echo with Peter's comments, this transformation, and Dr. Halsey alluded to this, this is turning an industry on its head. This is our Kodak moment. Peter and I were talking about this. When do we switch to digital when we know that film is still making the money? And that's where we are in healthcare right now. And we have made huge investments because, and I really have to say that when I look back, it's really mind-boggling to me to have had a board 12 years ago understand that the reflection of the PHP premium increase wasn't just because we were running a derelict health plan or, and just saying, just drop it, sell the plan. They were saying there's a root cause of a problem here, and as employers, we understand that this is a cataclysmic event for the community and that the health system needs to be at the lead. And we started making $1.5 million a year investments in this health improvement. And so it's actually been an investment, and it's also reduced what drives our economic engine. We've creatively destroyed the need for hospitalization, but I agree with Peter, there's going to be way more of it as we look at going to digital.
Georgia, I'm afraid as I look at the clock, we are at our 9 o'clock, and our promise to you is to allow you to leave at 9 o'clock. There are actually several more questions that I'm afraid we're not going to be able to get to. What we will do from this point is, number one, we will share these slides with you. I will send out an email to you in the next couple of days that includes all the links to the presentations that we've given today. Also, when the website is available for the Clinically Integrated Network, which is called Jackson Health Network, we expect that to be in the next 30 to 60 days. We will also keep you informed on that as well, mainly by email. Our pledge again is to continue this dialogue because, like Georgia said, this is a cataclysmic event for not only the health system, but it's us as a community and as a nation as well. So we appreciate the community dialogue moving forward and expect other types of events, maybe even in addition to Breakfast for Business, where we can be in touch with you and carry this conversation forward. Georgia, any closing thoughts?
We appreciate that. I'm glancing at the questions here, and I'll work with Chad to either through the Breakfast for Business website or something, since we have electronic communications, be able to share some of this feedback with you, because these appear to be very thoughtful questions, and I know that this has an impact directly on your business as well. So thank you all for coming, and we also, on behalf of Allegiance Health, wish you a very happy holiday.